Hello, this is again Professor Nick, Triple N, Nick Nikolaev Nikol, or PA Nick from Brooklyn, New York. Today is April 22, about 11 a.m. I would like to introduce you my pulmonary PANP board review notes. This is part one. We'll start from first slide, which is asthma. But before we start, if you have any questions, here's my email, which is nickmd1@gmail.com. You can email me any suggestions or recommendations for my performance, or if you have any questions, let me know. Let's start with asthma. By definition, asthma, this is a reactive airway disease with abnormal bronchoconstriction of the airways. The asthma is a reversible obstructive lung disease, and this is the main difference between this disorder and COPD, or chronic obstructive pulmonary disease. Etiology, the etiology is unknown generally, and we know that asthma is extremely common. Probably there is an association with atopic disorders or obesity. There is a clinical tip here which states that asthma prevalence, incidence, and hospitalization rates are all increasing. Let's talk about the probable causes for acute exacerbation of the asthma symptoms. Number one, this is allergens such as pollens, dust mites, cockroaches, or cat dander. Number two, infections and cold air. Number three, emotional stress or exercise. Number four, this is related to the menstrual cycle, or so-called catamenial. Let's go to the next slide, slide number 2. Also, asthma can be related to aspirin, NSAIDs, beta blockers, histamines, any nebulized medications, and tobacco smoking. Also, asthma is related to GERD, or gastroesophageal reflux disease. How the asthma presents. Usually presents with wheezing, with acute onset and shortness of breath, cough, chest tightness, and what makes the most likely diagnosis question, if you have it. Also presents with increased sputum production, which is very common. Also fever. Fever is not really well presented. A patient could have fever or doesn't need to have fever. It's not mandatory. There is a clinical tip here which states that the oral temperatures may not be accurately measured in patient breathing fast. Mild breathing cools the thermometer. If you have the following question, which of the following is most likely associated found in this patient? And we'll see that it's mostly the symptoms worse at night. Number one. Number two, can have a nasal polyps and sensitivity to aspirin. Number three, eczema or atopic dermatitis on physical exam. Number four, increased length of expiratory phase of respiration, and also increased use of accessory respiratory muscles or intercostals. There is another clinical tip which states that to the answer of which is the best initial test for asthma, this you need to think logically that this is based on severity of presentation. And there is another clinical tip which states that make sure that you can identify the sound of wheezing. This is good multimedia question. Let's go to the next slide. The next slide is how to diagnose asthma. The best initial test for acute exacerbation, this is PEEP or peak expiratory flow, or ABG, arterial blood gas. The peak flow can be used by patient to determine the function. Chest X-ray is most often normal in asthma, but may show hyperinflation. Chest X-ray is used for, number one, to exclude pneumonia, number two, to exclude other diseases such as pneumothorax and CSF. Here there is another clinical tip which states that asthma can be presented exclusively with a cough. Let's go over this table which shows different capacity and volumes of the lungs. The most accurate diagnostic test, this is PFT or pulmonary function test. Spirometry will show a decrease in ratio of FEV1 and which is forced expiratory volume in 1 second, and FVC, which is forced vital capacity. In most cases, FEV1 decrease more than FVC. Let's go to the next slide. This slide, we have a clinical vignette which states that a 15 years old boy comes to the office because of occasional shortness of breath every few weeks. Currently he feels well. He used no medications and denies any other medical problems. P reveals pulse of 70, RR of 12, chest exam is normal. Which of the following is the single most accurate diagnostic test at that time? A, peak expiratory flow. B, increase in FEV1 with albuterol. C, diffusion capacity of carbon. D, monoxide. C is more than 20% decrease of FEV1 with use of methacholine. F, increase of your arterial oxygen difference, or A capital dash A lowercase gradient. G is increase of FVC with albuterol. H is flow volume loop on. And F, this is spirometry chest CT scan. The right answer here is obviously D, and the explanation is when a patient is currently asymptomatic, it is likely to find an increase of FEV1 with the use of short-acting bronchodilators such as albuterol. This test, when the patient is asymptomatic, may be falsely negative, but if the patient is asymptomatic, the most accurate test for reactive airway disease is 20% decrease of FEV1 by using a methacholine or histamine. Let's talk about now about pulmonary functional testing in asthma. PFTs in asthma are as shown. Number one, decrease FEV1 and decrease of FVC, as well as the ratio FEV1 slash FVC. Number two, there is an increase of FEV1 more than 12% or 20 milliliters with use of albuterol. Number four, decrease of FEV1 more than 20% with the use of methacholine or histamine. And the last one is number four, increase of diffuse capacity of the lungs with the carbon monoxide, so-called DLCO. And here there is a clinical tip which suggests that PFTs are normal in between exacerbations. So we need to basically use acetylcholine or histamine to provoke bronchoconstriction and increase of bronchial secretion. For methacholine, this is an artificial form of acetylcholine, which is used for diagnostic testing. Additional tests include CBC will show increased eosinophil count. For asthma to be diagnosed, there is a clinical tip here which suggests that number one, if FEV1 increase with 12% using albuterol, and if the FEV1 decrease with 20% by using methacholine. Also, we can do skin testing to use to identify the specific allergens that provoke the bronchoconstriction. Increase of IgE levels suggest for allergic etiology of the problem. IgE levels also may guide for the therapy if we're using anti-IgE medications such as omalizumab. If we have increase of IgE levels, this is also associated with allergic bronchopulmonary aspergillosis. Treatment for asthma is very complicated. That's why we need to pay very close attention. Asthma is managed by a stepwise fashion, progressively adding more types of treatments if there is no response. Step one, always start with inhale short-acting beta agonists, also called SABA. Example for SABAs are albuterol, then purbuterol or levalbuterol. Also, there is step two. We can add long-term control agents to a SABA, which is low-dose inhale corticosteroids or ICS, and this is the best initial long-term control agent. Examples are beclomethasone, budesonide, flunitrazide, fluticasone, memetrazone, and triamcinolone. And let's continue. This is again PANP, and let's start from slide 6. Slide 6 suggests that the side effects of inhaled steroids are dysphonia and oral candidiasis. Also, there is a alternative long-term control agents, which includes cromolyn, medications such as cromolyn or nedocromolyn, which inhibit the mast cells mediator release and eosinophil recruitment. Also, number 2, this is theophylline, and number 3, leukotriene modifiers. Montelocast, zoprizolcast, and Zileton, the best with atopic patients. There is a clinical tip here which suggests that the Zoprizolcast is hepatotoxic and associated frequently with Churg-Strauss syndrome. There is a step 3 in treatment of asthma, which states that we can add a long-acting beta agonist or LABA to SABA or ICS, or increase the dose of ICS. LABA medications are such as someterol or formoterol. And step 4, what we can do is increase the dose of ICS to the maximum, and and additionally we can add LABA or SABA. We can add tiotropium, which is an anti-muscarinic agent. There is a clinical tip here which states never use LABA first or alone. There is a step 5. We can use omazumab, which can be added to SABA, LABA, or ICS in those who has increased IgE level. And the last step is number 6. We can use oral steroids such as prednisone, which can be added to all other therapies when all other therapies are not sufficient to control the symptoms. Also, there is a side effects of the systemic corticosteroids, which states that they can be used as a last resort because of the harsh side effects. Let's go to the next slide, slide number 7. The side effects of corticosteroids, as we said, this is osteoporosis, number 1. Number 2, cataracts. Number 3, adrenal suppression and fat redistribution. Number 4, hyperlipidemia, hyperglycemia, acne, and hirsutism, particularly in women. Also, we can have thinning of the skin, stria, and easy bruising. There is a clinical vignette here which states that high-dose inhaled steroids can lead to side effects associated with prednisone. Let's talk about anticholinergics, which are so-called ipratropium or tiotropium. They're used for asthma management if SABA, LABA, or inhaled steroids are not sufficient. Anticholinergic agents will be dilating the bronchioli and decrease the secretion. They are very effective in COPD. Influenza and parainfluenza vaccines are given to all asthma patients. Let's talk about another important topic, which is treatment of acute asthma exacerbation. We'll start with the clinical vignette, which states that a 47-year-old man, which has history of asthma, comes to ER, emergency room department, because of several days of increased shortness of breath, cough, sputum production. On physical exam, he has a respiration rate of 34. He has diffuse expiratory wheezing and prolonged expiratory phase. Which of the following are the best indication of the severity of his asthma? Oh, that's a good question. The possibilities are A, respiratory rate, B, use of accessory muscles, C, pulse oximetry, D, pulmonary function testing, and E, pulse rate. Let's think a little bit. And here the right answer is A, because of which is the respiratory rate. Explanation is very simple. The normal respiratory rate is between 10 and 60 per minute. By itself, by respiratory rate of 34 indicates severe shortness of breath. Accessory muscles is very hard to assess. It's subjective. Pulse oximetry does not show hypoxia until the patient is near the imminent respiratory failure. Oxygen sat, if it is above 90%, that's all right. So the right answer is A, respiratory rate. Let's go to the next slide. Let's continue. And the treatment of asthma exacerbation, the best initial therapy, this is oxygen combined with inhaled short-acting beta agonist, such as albuterol, and a bolus of steroids. Corticosteroids, they need it for 4 to 6 hours before they begin to work, so they need to be given right away. Epinephrine injections are not more effective than albuterol, and the more side effects that should be used. Ipratropium should be used, but does not work rapidly as albuterol. Magnesium also, there is a clinical tip here which states that the magnesium can help with a relief of the bronchospasm. Magnesium is used only in acute severe asthma exacerbation, which does not respond to several rounds of albuterol while waiting for the steroids to take effect. This is a clinical tip. Slide number 10 talks about that tobacco smoking leads always to COPD. Basically, the tobacco or nicotine destroy the elastin fibers. And there is a here clinical tip which states that in case of the patient is young and non-smoker, you should answer always alpha-1 antitrypsin deficiency as a most likely cause. How presents? Number 1, shortness of breath, which works with exacerbation. Number 2, intermittent exacerbation, which increase the cough, the sputum, shortness of breath, frequently by infection. Number 3, barrel chest, which is due to increased air trapping. And number 4, muscle wasting and cachexia. The diagnostic tests is the best initial test is chest X-ray, which shows increased AP diameter or anterior-posterior diameter, the air trapping, and flattering of the diaphragms. Let's go to the next slide, number 11. On figure 6/2, it shows a chest X-ray of patient with COPD. So the most accurate diagnostic test, this is PFT. PFT shows a few things. Number 1, decrease of FEV1, decrease of FVC, and also the ratio, decrease of FEV1 / FVC ratio, which is under 70%. Also, number 2 shows increase TOC because of the increase of residual volume. Number 3, there is a decrease of DOCO in case of emphysema, but not in chronic bronchitis. Number 4, incomplete improvement with albuterol. And number 5, little or no worsening with methacholine. Also, we need to discuss here is reversibility with inhaled bronchodilators. Patients which have COPD, they have a broad range of response to inhaled bronchodilators, such as albuterol. The range ranges from no reversibility to complete reversibility. About 50% will have some degree of response. Also, we need here to take a look at this clinical tip, which states that full reversibility in response to bronchodilators is defined as greater than 12% or 200 milliliters increase of FEV1. So the numbers here are 12% and 200 milliliters or cc. Let's go to the next slide. Next slide is number 12. Let's discuss what is the plethysmogram. A plethysmogram shows an increase of residual volume and is not used frequently. Let's talk about arterial blood gas or ABG. In acute exacerbation of COPD, there is increase of PCO2 and hypoxia. Usually develops respiratory acidosis which is may present it, and if there is no insufficient metabolic compensation, and bicarb level will be increased to compensate it. In between exacerbations, not all those with COPD will retain CO2. Also, we can do CBC. We have increase of the hematocrit in case of chronic hypoxia. EKG shows two things. Number one, right arterial hypertrophy and right ventricular hypertrophy. And number two, arterial fibrillation or MAT, M-A-T, multifocal atrial tachycardia. Also, echocardiography will show two things. Number one, right atrial and right ventricle hypertrophy, and number two, pulmonary hypertension. The treatment is to pay attention to the factors or the medications or treatments which improves the mortality and delays the progression of the disease. This is number one, smoking cessation. Oxygen can be used if chronic oxygen if PO2 is less than 55 and SAT is less than 88. In case of pulmonary hypertension, high hematocrit or cardiomyopathy, and if the PO2 is less than 60 and SAT is less than 90. Oxygen therapy for those which these ones which have saturation less than 88, mortality benefit is directly proportional to the number of hours that the oxygen is used. Let's go to the next slide, number 13. We need to give this patient influenza and pneumococcal vaccine. Definitively, all this will improve the symptoms, but does not decrease. We're already on slide 13. As we said, definitively will improve the symptoms, but does not decrease the progression or mortality of the disease. Number one, short-acting beta agonist, such as albuterol. Number two, anticholinergic agents such as tiotropium, ipratropium, aclidium, and umeclidium. Number three, steroids. Number four, long-acting beta agonists such as albuterol and formoterol or ledaretol. Also, pulmonary rehab we can use. Here there is a clinical tip which we need to pay attention, that inhaled anticholinergic agents are more effective in COPD. Ipratropium is only used in acute exacerbation. Let's talk about, there is a clinical tip which states that asthmatics which are not controlled by albuterol, we can use inhaled steroids. COPD which is not controlled by albuterol, we can use anticholinergic such as tiotropium, inhaled steroids. If possibly the symptoms improve, we can use theophylline or number two, lung volume reduction surgery. we can do also. There is a clinical tip which states that when all medication therapies are insufficient, the answer is refer for transplantation, lung transplantation. Let's go to next slide, which is number 14, which does not have benefits. This is cromolyn, number 1, and number 2, leukotriene modifiers such as montelukast. How do we treat acute exacerbation in chronic bronchitis? Usually by management of acute episodes of increased shortness of breath, which is similar to treatment of acute asthma exacerbation. The use of bronchodilators or corticosteroid therapy is combined with antibiotics, and ipratropium is the only anticholinergic agent used acutely. There is another clinical tip which states that AECB treatment is identical for asthma treatment, but just with less proven benefit. Antibiotics are generally used for acute exacerbation of chronic bronchitis, or abbreviation for this is AECB, because of the infection is far most commonly identifiable cause. Which is the most effective in this case? Although the virus is about 20 to 50% of episodes, coverage should be provided against strep pneumo, H. influenza, and Moxarella catarrhalis. Number 1 antibiotic, this is macrolides, as azithromycin and clarithromycin. Number 2, cephalosporins such as cefuroxime, cefixime, cefalcor, or ceftiburan. And number 3, this is amoxicillin clavulinate. Also, we can use quinolones like levaquin, moxifloxacin, and gemifloxacin. There is so-called second line agent as a doxycycline or trimethoprim sulfamethoxazole. The criteria for use for oxygen in COPD are the following. Oxygen can decrease the mortality. The criteria are the following. Let's go to the next slide, number 15. Let's discuss next clinical topic, which is bronchoectasis. Bronchoectasis, by definition, this is uncommon disease of chronic dilation of the large bronchi. This is basically permanent anatomical abnormality that cannot be reversed or cured. This is uncommon because of right now, because of the better control of the infection of the lungs, which lead to weakening of the bronchial wall. The etiology, the single most cause for that is cystic fibrosis or CF, which accounts of 50% of or 1/2 of the cases. The other causes can be infections like TB, pneumonia, abscess. Number 2, pan-hypogammaglobulinemia and immune deficiency. Number 3, foreign body or tumors. Number 4, ABPA or allergic bronchopulmonary aspergillosis, and number 5, collagen vascular disease such as RA or rheumatoid arthritis. What is the clinical presentation? Or if they ask questions such as what is the most likely diagnosis? Basically, acute episodes of very high volume purulent sputum production is a key of suggestion of the diagnosis. Hemoptysis can occur. Dyspnea and wheezing is presented in 75%. Other findings are number 1, weight loss, number 2, anemia of chronic disease, number 4, crackles on lung enzyme, and number 4, Cobbing, which is uncommon. Also can have dyskinetic seizure syndrome. There is so-called such kind of clinical tip which states that it is impossible to diagnose bronchiectasis without the imaging study of the lungs such as CT scan. Let's go to the next slide. Next slide shows on figure 6/3 bronchiectasis with widening the bronchi in multiple areas. So the diagnostic test, the best initial test is a chest X-ray, which shows dilated, thickened bronchi, which have so-called tram tract, which is thickening of the bronchi. The most accurate test is a high-resolution CT scan. There is so-called sputum culture, which is the only way of determining of a specific bacteria etiology of recurrent episode of infection. Treatment is number 1, chest physiotherapy, which is cupping and clamping, and postural drainage, which are essential for dislodging of plug up bronchi. Number 2, treatment of each episode of infection, which is on the rise. It is used the same antibiotics as for exacerbation of COPD. The only difference is that inhaled antibiotics seems to have some efficiency, and specific microbiological diagnosis is preferable since so-called Mycobacterium ovarium intracellulare, or the abbreviation is MAI, can be found. Number 3, we need to rotate the antibiotics weekly each month. And number 4, surgical resection of the focal lesions may be indicated. Let's go to the next slide. Next slide discuss so-called ABPA, or allergic bronchopulmonary aspergillosis. The definition of etiology is ABPA is hypersensitivity of the lungs to fungal allergens that colonize the bronchial tree. ABPA occurs almost exclusively in patients with asthma and history of atopic disorders. What is if the question asks what is the most likely diagnosis? You need to look for asthmatic patient with recurrent episodes of brown flecked sputum and transient infiltrates on chest X-ray. Also, patient present with cough, wheezing, hemoptysis, and sometimes bronchiectasis can occur. The diagnostic tests, we can see a peripheral eosinophilia, number 1. Number 2, skin test reactive to aspergillus antigens. Number 3, precipitating antibodies to aspergillus on blood test. Number 4, elevated serum IgE level. And number 5, pulmonary infiltrates on chest X-ray or CT. The treatment is number 1, oral steroids, prednisone for severe cases. Inhaled steroids are not effective for ABPA. Number 2, interconazole orally for recurrent episodes. There is a clinical tip here which states that an inhaler cannot deliver a high enough dose of steroids to be effective for treatment of ABPA. And this is the last slide and the end of the part 1 of the pulmonary PANP board reviews notes. Once again, this is part 1, and once again, this is PA Nick, and my email is, if you have any questions or suggestions, nickmd1@gmail.com. Thank you so much.